We actually found we were quite good. Few people who joined this summer. There was a fever about employing doctors this summer from Zahra. So we were like 10 of us this year. More of us from the British Isles. So it was a pleasure to work with him. He heads the pain management unit. Obviously his background is anaesthetist, and he has a special interest in pain management. I'm sure we're going to enjoy his lecture. Thanks, Dr.
Good morning, Steve. My name is Dr. Anwar. I'm a anaesthetist, and I was trained in Ireland, and did my fellowship at MSc, and did my pain fellowship in St. Vincent University Hospital, which is very well-known pain management unit in that hospital, and also worked in the Beaumont Hospital, Dublin, which is also, I worked there as a pain specialist registrar. Now, just start without wasting time to come to this topic. This is failed back surgery syndrome. As our colleagues do a lot of spine surgery, so about 10 to 20% in USA and UK, they see that pain still persists after the surgery. But what should be the problem? So we have to diagnose the problem and have to treat. The surgery is the one which was done for the pain, and then even after that, the pain persists. So what happened? So we have to diagnose and then have to treat that one. So once surgeons stop that treatment, then we have to take over and have to treat the patient. Neuromodulation is one of the techniques which we use to treat this pain failed back surgery syndrome. And I'm going to talk more about this neuromodulation. And I work in a neuromodulation center in Dublin. What is failed back surgery syndrome? It is as Dr. Khadoon said, biopsychosocial disorder, right? He said. And apart from the pain, there are certain other factors, and defined as continued back pain or extremity pain following the spinal surgery. So it's a complex set of symptoms encountered after a patient has had surgery on the lumbar spine for disc-related pathology. So pain still persists. It's a persistent, recurrent pain, mainly in the region of low back and the legs, and even after technically anatomical successful lumbosacral spine surgery. Even after the successful surgery, you develop the pain. So what is this actually? This is could be purely organic, then physical abnormality complicated by psychological factor. These are the most of the cases, and then can go further to the purely psychological. So there is a spectrum with this disease. So what is incidence? As I said, we were having 15 to 20% of our patients after the spinal surgery. This problem in our clinic, so we used to treat this. And in the literature, most of the literature, it is mentioned that in 15 to 40% patients, they come up with this syndrome. So it's same the same as for rheumatoid arthritis, 10 times more than the complex renal pain syndrome, 10 times less than the fibromyalgia, and 100 times less than the osteoarthritis. What are the causes? There are various causes of the failed back surgery syndrome: deconditioning, muscle spasm, myofascial pain, spinal instability, discogenic pain, tested arthropathy, infection, pseudoarthritis, loose hardware, retinitis, trauma, wrong levels fused, insufficient level fused, and pseudomeningocele, and a graft donor site. So these are the various causes of the back pain. Now, if you see the facet joint arthropathy, there is a facet joint. Here is the facet joint, which is called as zygopophyseal joint, which is the articulation between two vertebrae, and here there is a capsule there. And one of the nerves which comes from the here, which is the medial nerve branch, which supplies this facet joint, and actually it is the irritation between for this nerve, and that causes lead to the pain. Again, muscle conditioning, Dr. Khadoon also mentioned about this. is very common. What happens in this? There is an inflammatory cell apoptosis which leads to the decreased aerobic fiber, and leading to that lactic acidosis and lactic toxicity to the muscle decondition which causes pain. Again, instability, vertebral instability after surgery even, they cause the spinal decompression, and also the segmental instability. This also leads to the pain. Pseudoarthrosis also, there is a failed fusion which also lead to the pseudoarthrosis causing pain. And as I mentioned, the loose hardware, you see the loose screw there, and there is a space there in this imaging. So that shows that also causes the pain. And also, some of the screw, they can be misplaced and causing the nerve injury, and that leads to pain. Arachniditis is the fibrosis, inflammation, irritation in the arachnoid membrane, and also leading to the scarring and adhesions, and finally calcification, and that causes pain. Again, pseudomyelin, this is also one of the causes of pain. As infection also lead to the pain as well. Scarring of the nerve tissue, as you can see this, after the surgery, it can lead to the scar, and scar causes more pain, and it sends the pain signal to the brain, and that leads to the pain. Now, what are the causes of the leg pain? Retained disc fragment, recurrent herniated mucopulposis, fall lateral disc, lateral recess stenosis, inadequate decompression, wrong level decompression, nerve root injury, retained foreign body, epidural fibrosis, arachniditis, synovitis, root sleeve meningocele, loose hardware, and the fascial fracture. So these are various causes also causes the pain. Again, surgical cause more or less the same. Again, these are the same definition. What is the pain mechanism? It's a complex problem. So pain could be nociceptive leading to neuropathic pain, and then combination of nociceptive and neuropathic pain. So the spectrum can appear. It's easy to diagnose but difficult to treat, as the causes of pain are maybe organic factor, which I mentioned, social factor, and psychological factor. Again, neurotransmitter in the spinal cord, they have a big role there, and there are various receptors in this spinal cord, dorsal cord, and where they remodify the signal, pain signal, and these signals are rearranged and sent to the brain, and where they cause pain. Now, gate control theory happens to occur. Pain perception, what happens? A delta fiber, C fiber, coming to the dorsal column, and from here A beta nerve fiber. If inhibited neuron not activated, then lead to the pain signal to the brain and cause the pain. What happens to the pain modulation? Here at this level, the pain signal are stopped due to the interruption of A beta fiber, and that is the mechanism of the gate control theory. And neuromodulation also, we do mechanism with neuromodulation with this. Again, central sensitization, again the pain signal goes to the various receptor release of the neurotransmitter, and that leads to the hyperexcitability of the neuron, causing allodynia and hyperalgesia. What is the management of pain pattern? So there should be some goals. So these goals are functional improvement, improvement of the physical activities and exercise tolerance. There should be reduction in pain, and there should be reduction in the narcotic use, and reduction in the healthcare congestion, and the return to work. So management, initial assessment and imaging, as my other colleagues have mentioned very thoroughly about this, and then pharmacotherapy, intervention therapy, multidisciplinary work, neuromodulation, DRS and PNS, and industrial pharmacology. There should be comprehensive assessment. I don't want to go into detail, but just want to mention a few things. We should thoroughly assess pain's severity, functional disability, quality of life, dorsal column assessment, psychological assessment. So these are how we can do the primary review. We should, when the patient comes and say that he had surgery, and after surgery he got spinal pain, and then we get all the details of operation, some from the department hospital, and then we re-evaluate the yellow flag, as Dr. Khaldoon mentioned, the yellow flag should be reviewed, and then proper thorough assessment, investigation, and then we decide whether to go ahead for the neuromodulation technique, or pharmacotherapy technique, or some other interventional therapies. Depending upon that, we'll decide further. And we discuss, we take our surgical colleague on board, orthopedic surgeons, with spinal interest, and they also give very good input on this. Don't want to go into details, already mentioned by my colleague, imaging very well mentioned by Dr. Raji. Surgical opinion, this is a must. Ideally, the need for further surgery should be ruled out before the patient is referred to the pain physician. This is very, very important, because most of the patients come with that. Surgical opinion should be sought if not already obtained, especially if there is suspicion of new or recurrent disc prolapse or permanent stenosis. And a randomized controlled trial comparing repeat surgery with spinal cord stimulator suggested that repeat surgery has poor results. This is published in one of the neurosurgery papers. Treatment options, as I mentioned, pharmacotherapy, gabapentinoid, antidepressant, opioid, psychotherapy, physiotherapy, interventional therapies, and invasive therapies. Interventional therapy, we can use the epidural, precedent denervation, and laminar epidural. And in invasive therapy, we can use spinal cord stimulator and dorsal root ganglion stimulator and intrathecal form. Pharmacotherapy, normally we use this gabapentinoid, an antidepressant, duloxetine, and also the opioid. Now these drugs, they do work, but not very much work, because they take off the pain 20 to 30%, but in very minority of the patients, various papers have shown their efficacy. Gabapentinoid has, still we have to use this medication because there is no other specific medication for that, but these also work on certain receptors. Duloxetine, this has got certain effect. In various studies it is shown that it has got certain effect in pain management. Now, opioid, the people are using the opioid very commonly, but they have certain side effects like immunosuppression, endocrine suppression, reduced libido, and overall detrimental effect, quality of life, tolerance, addiction, and respiratory depressions. They are all very known, but the people are being using a very high doses in Europe and Western world, and due to this pain, because there is no other pain modality. A certain patient doesn't want to go for the surgery, surgery or neuromodulation techniques, so they have to rely on these medications, and then they are getting these side effects. Now, interventional therapy, they are transforaminal epidurals, precedent block, caudal epidural. They are used for temporary basis, and for the option being used in certain patients to get comply with ongoing exercises, to reduce the medication use, and to avoid repeat surgery. This topic, Dr. Ali Aziz, my other colleague, he mentioned in his talk in chronic pain management. So same epidural, we will give epidural 2 ways, transforaminal, and same facet joint block also given, and we block in a facet joint, and also we block the median nerve, the nicotine. Again the same. And radiofrequency ablation, also my other colleague will mention about this. And again, once the median nerve block is effective, we give this radiofrequency ablation, and we give heat therapy to these nerves, and they are effective for about 6 months. Again, that is often the same. Now, neuromodulation. Neuromodulation is a technique which is based on the gate control theory. And spinal cord stimulator, what happened? We just introduced the wire into the epidural space, and from the wire we have electrodes. And these electrodes we aim particular level where the pain is expected to be there, and then we attach this wire to the IPG, which is the pulse generator, and from there we have a remote control, and we just give signal to those nerve fibers, and they then change the perception of pain due to producing the paresthesia. Same, it is once the impulse is off, the pain is there. Once impulse generated, the pain modulated. So it causes the paresthesia. So spinal cord stimulator, IPG, wires, and this remote control. Spinal cord stimulator neuromodulation patient should not be considered as a last-ditch effort, but should be offered early in the management of the management plan. Neuromodulation may be unavailable locally, as we don't have in this area, in this part of the world. So referral to the neuromodulation center should be made once it becomes clear that the patient has failed to respond to conventional, locally available, conservative and interventional treatment. The early referral and application of the neuromodulation has been shown to increase success in FBSS. For neuromodulation, you should have a full team. There should be pain physician, there should be psychologists, there should be physiotherapists, and there should be neuromodulation nurses. And also, the close cooperation with the spinal surgical team may be beneficial, especially to deal with the hardware-related issue or neurological complication from neuromodulation. Neurological complication can occur, it can produce infection, abscess, and there is breakage of electrode and misplacing and migration of electrodes. These are all the complications can appear after the neuromodulation spinal cord stimulator. So we should take the help of spinal surgeons. Now, what is there should be a selection of suitable patients. This is very important because not every patient can be selected. Pain clinician assessment is very, very important, whether this patient should need to go for spinal cord stimulator, or whether this patient need conservative therapy, or they will need surgical intervention. Psychological assessment and counseling is very, very important because it is a biopsychological social disorder. So many patients, they should be very much clearly assessed by the psychologist, and they use various tools to assess psychological status of the patient before they send to the neuromodulation unit. And there is a need for neuromodulation because after the spinal cord stimulator, they have to keep in touch with the neuromodulation nurse so that they can give increase or decrease of the stimulation, whatever, and they can give the device to the patient. And pain management program is the one which also helps in this condition and also deal with the complication follow-up. There are emerging neuromodulation technique, high frequency spinal cord stimulation, dorsal root ganglion stimulation, peripheral nerve field stimulation. They are upgrowing now commonly. Recently, in 2010, they started this narrow technique, and they use very high frequency spinal cord stimulator, and it has also very good effect. Dorsal root ganglion stimulation, they instead of putting into the epidural space, they put a wire slightly into the dorsal root ganglion. They do that through X-ray guidance. You can see these wires, electrodes, and it is very, very effective. And as the data, so far the data available show that it is much more effective, much more localized as compared to spinal cord stimulator. Same, if you can see this spinal cord dorsal root nerve stimulator, the electrode has gone there, and it is very, very effective as compared to still emerging. Then peripheral nerve field. Sometimes the back pain, local back pain, and we have to just go this electrode in the field of the nerve field. We have to put this electrode in either way where there is a pain, and then we put the battery IPG under the skin, and then with the help of remote control will give the pulses, and that causing the paresthesia instead of the pain. So patient this is very helpful in this technique. Then intrathecal pump, in a very refractive cases, we put this catheter into the spinal cord, and then we use the medication. We fill this pump with morphine and dihydromorphine or various other medication, and because this directly going to the spinal cord, so the dose is very, very slow, and it is being controlled by the remote control device. Now, what is failed back surgery syndrome? Is a complex entity that can cause considerable disability, distress to the patient, and immense economic impact on the healthcare. So, management of this patient requires a thorough assessment and early referral to a secondary or tertiary referral center for further management. The effective management plan for these patients within the context of multidisciplinary team approach, and many patients may be significantly helped by the above approach, and there is considerable revolution in the field of neuromodulation, and the number of the patients who may benefit is likely to increase in near future in this condition. Thank you.
Dr. Anwar, thank you very much. Any question to Dr. Anwar?
I am Dr. Falala. Thank you, sir, for this fantastic demonstration. I want just to ask you a question. Do you agree or do not? Before embarking on any disc or vertebral surgery, why not think of osteoporosis? Because two patients I know personally were operated upon.
Pain management, what happens, as I mentioned, we have to go thorough. Pain management means that we have to assess the patient. So we use all the tools and investigations before going to further treatment of this condition. So if we thoroughly assess, investigate properly, then we reach the diagnosis. As you mentioned, osteoporosis was the cause. And surgeon and pain clinician do think about this and they go accordingly.
What is your experience regarding continuous caudal epidural using hydraulics or like in FBSS?
This FBSS, as I mentioned, intervention therapy does work, but it's not very effective. It's a very, very temporary relief. So what we use is we give a steroid with the local anesthetic combination, not the normal saline, the steroid with local anesthetic combination, and they affect certainly for about 6 weeks to maybe a little bit more in certain areas, but not they give the full relief of this pain, because already they are very, very irritated nerve, hyper-excitable nerve, neurons very hyper-excitable, and they are sending a various pain, different pain signal to the brain and heart centers. So that's why these intervention therapies, they do help to certain limit, and also for the purpose of like physiotherapy. They have very, very severe pain. Yes, we give some this for initially this epidural. The patient gets relieved within 2-3 days, and for about 10-15 days, maybe to 6 weeks. And then during this period, what happens is patient have also the physiotherapy technique and all that, so they also help in this area.
Okay.
Hi, I'm Dr. Mohammed. In fact, I just want to ask, when will you use spinal cord stimulation and when will you use the bilateral pump? Thank you. Sorry, the morphine pump.
Morphine pump. Yes. As I mentioned, it's a very refractive. You know, the pain is a bio-psychological social disorder. So we have to go through thorough investigation and evaluation of the patient. Now, the patient, if we see that this patient is this pain can be settled with the neuromodulation, we go first to neuromodulation. And then, if some of the patients doesn't have relief with neuromodulation technique as well, there is a failure there as well, not 100% patient relief. And the patient's pain is such a chronic, they are dependent before going for neuromodulation. They were having the OPI, they were using the OPIs. But then, in those cases where there is a refractory pain, we go for intrathecal pump. And then intrathecal pump, the idea is to give a less dosage so that they can have those side effects which I mentioned, the less side effects. So that's why we give the intrathecal pump.